Hello and welcome to the Hooked on Health podcast. I'm your host, Dr. Sean Lordan, and with me today is Dr. Gunardi Irawan, a medical weight loss specialist and an internal medicine doctor. So, uh, Gunardi, just tell us a little bit about yourself and, how you become a doctor and get specialized in obesity medicine.
Thank you, Sean, for inviting me on the podcast. The reason why I became a doctor is because my father was a great influence on me when I was young. He's a family physician practicing in a rural town, and he knew his patients really well. And I really like that part where he gets to know his patients really well, and patients are very grateful. So I pursued my medical degree in Germany, and then I did my medical residency in Framingham here in Massachusetts. And then I went on to um, be an attending in primary care physician in University of Massachusetts in Worcester before opening my own private practice in Northborough. Yes.
Yeah, that's great. So obviously you're specialized still in internal medicine, and now you're focusing more on medical weight loss and weight management with patients. Talk to me about how you really transferred or kind of started to focus. Walk me through the journey of focusing on medical weight loss.
Yes. So um, in the past, where we used to treat medical conditions, let's say, for example, high blood pressure or diabetes. We try to we counsel patients, try to encourage patients to do lifestyle modification, but we also prescribe medication to treat that condition. But I think I realized something that we could treat the root cause on most of these conditions by most of the time treating weight and obesity. That's why when we treat obesity, we also help with the other conditions too, like high blood pressure and diabetes. So it's much more effective. Patients have higher quality of life that way. Um, for example, when we treat patients with just let's say focusing on diabetes, some of the diabetes medication may be weight gaining. So it might help reduce the blood sugar at that point. But long term, patient may gain weight with some of the diabetes medication. But when we focus on obesity, when we focus on weight, um, and also focus on diabetes, we treat the root cause, and that will help the patients long term. Yeah, and that is why um, after 6 years of being an internal medicine specialist, I pursued further board certification in obesity medicine, and currently I'm board certified in both.
That's incredible. Can you walk us through the audience through what it takes to become board certified?
Yes. So first, one needs to become board certified in a specialty, either internal medicine or other specialty, um, and then one needs to apply to Obesity Medicine Association, and we need to accumulate about 120 continuing medication education points. So that took me about a couple of months, and then we need to sit for the board exam, which is about, in my probably is about 4 to 6 hours board exam. And then the whole journey took for me about 1 year of doing that. And then after that, after you pass the exam, then they give you the diploma and board certification. And then to continue that, you need to still do the continuing medical educations every 2 years. Yeah.
Yeah.
And yeah, but I really enjoy that. And I think it's been very rewarding and fulfilling for me helping the patients. And they have had a lot of success and achieved their health goals.
Yeah. Can you walk us through, Gennady, the changes really, because medical weight loss management has changed a lot over the past decade, or really since, for me, coming up through physical therapy school 15 years ago when I graduated, um, you know, it was a much different approach back then. Really, you're exactly right. It's treating comorbidities like hypertension, HLD or hypercholesterolemia, and or hyperlipidemia and diabetes, right? And now we have different options. So can you walk us through maybe the last 10 or 15 years, what has changed and how you really focus in your practice to treat somebody as a whole person?
Yeah. So I think we as a medical community has managed to shift the focus from treating those comorbidities to focus more on obesity. Um, the the weight loss medications that we currently have are very safe, and it's been FDA approved. Yeah, and yeah, and I think it's been really helpful for a lot of the patients.
Yeah. So, I think the hottest trend recently are the GLP-1s. Um, can you just talk about sort of the brand name that they're known under and, how they really affected your practices?
So, I think the most known one are the Wegovy or the Zepbound. Those are the GLP-1 agonists to treat for weight. There are also GLP-1s to treat for diabetes. Those are Ozempic and Mounjaro. So, Ozempic and Wegovy are basically the same medication. They're just marketed under a different brand name, but they have the same exact medication in a different label, the same as Mounjaro and Zepbound. And what's exciting is that now we have a very effective medication that is safe to treat for weight. So in the past, uh, medications that were used to treat for weight loss were also effective, but they're about like say glycemia or phentermine topiramate. It affects about 10% of weight loss with nutrition and lifestyle modification. But now, in comparison to that, the newer medications like the Wegovy, on average, patients lose about 15% of weight, and one third of the patients lose about 20% of weight. And with the Zepbound, it's even greater. On average, patients lose about 20% of weight, and one third of them may lose about 25% of weight. So, in a patient who is, let's say, uh, 200 pounds, 20% weight loss is 40 pounds. So, um, and 25 is 50 pounds. So, that's uh, very impressive, and that's rivaling some of the uh, bariatric surgical options.
Yeah, so I guess, one of the biggest questions, and for, my approach to healthcare is generally holistic. Um, and I think a lot of our patients at concierge really try to, exhaust as many non-surgical options as possible. Um, and try to not go down the medication route if they absolutely don't have to. But I know we were talking off camera about this, but can you walk us through what it's like to, what you see with your patients struggling with traditional methods, like just trying to control their nutrition, control their exercise?
Yes.
Can you walk us through sort of some statistics around just diet and exercise versus the GLP-1s?
Yes. So we always advocate for lifestyle modification, nutrition counseling, and also increased activity. Um, However, as I mentioned to you, those lifestyle interventions are great for preventing weight gain. For treating weight gain, there needs to be a different strategy because, as we know in the big studies, um, only about 5% of patients who have monthly counseling and coaching um, and enrolling in the program, only 5% of them are successful in losing weight and maintaining it over 1 year.
Yeah.
Um, and the 95% is not able to do that. And it's not because of willpower, because we know a lot of patients are successful outside, they are successful in their careers. It's not just because of willpower and not being able to do that, but it is because of metabolic adaptation. So what I mean is, um, every every 10% of weight loss, the body reduces the energy expenditure by 25%. Um, Reason number two, every um, every time we lose weight and successfully, the body is stimulating the hunger hormone called ghrelin, and it increases the hunger that, and patients have increased food noise with that, and they're not able to maintain that. So it's like having a thermostat set at a different temperature or where you want to be. So that's why it's quite difficult. And we always try with nutrition counseling, and we always try with encouraging the exercise. That's why I have, as I mentioned, I have nutritionists in my team to help with that. For those patients who are not successful, then we can help with medication.
Yeah, I really like the thermostat,
Yeah.
analogy, right? So if your body, let's say like, I weigh 200 pounds,
Mhm.
right? And if I lose 10% of my body weight,
Mhm.
and I'm used to it being 70 degrees in the
Mhm.
room, but now it's 63
Mhm.
degrees, that's going to feel cold to me,
Mhm.
So then my body is going to call upon ghrelin, the
Yeah.
hunger hormone, and then it's going to say, go eat that donut or, you're hungry, so eat whatever's around. And
Correct.
it's,
Correct.
to your point, it's not just about willpower. It's
Mhm.
about, so many other things, setting yourself up for success, having healthy food options available, planning your day
Mhm.
and those things. What I also think about, and, correct me if I'm wrong, but I think I read this somewhere that your adipocytes never really go away. That's why, they can shrink, but you know, they don't go away. They don't just like
Correct.
die,
Correct.
so can you talk a little bit about, the adipocytes and sort of, maybe the role of plastic surgery and how, or,
Yes.
bariatric surgery and the different options?
So I have a few thoughts on that. So our body has very uh, complex mechanism. So the adipocytes, they do not go away, and
So adipocytes, just for the layperson, adipocytes are fat cells. So as you gain weight, your body can create more fat cells, but as you lose weight, that you don't, they just shrink. You can never get rid of them. But correct me if I'm wrong.
correct, correct. So that's why I'm referring to the metabolic adaptation before. Even right now, we realize fat tissue is not just a dormant organ. Yeah, they also produce hormones such as leptin. So leptin also plays a part in interacting with the ghrelin as well. So um, it's not a simple organ where it's actually an organ that produces hormone. Um, and then my second thought is we have differentiated between subcutaneous fat tissue and also visceral fat tissue. Um, with plastic surgery or I say liposuction, they might help lose the subcutaneous tissue, but not the visceral fat tissue, which is the fat tissue around the organ. This is what's actually more directly correlated to diabetes, insulin resistance, and also high blood pressure, high cholesterol as well. So um, the way to reduce the visceral fat tissue, which is a bad fat tissue, is of course with the lifestyle modification, um, and as I mentioned, the medication may help as well. I want to also share with you a study from the TV episode, "The Biggest Losers," where patients are trying to lose weight under constant monitoring. They have been really successful. Um, so most of the patients do regain weight after that. It's not because, as I mentioned, willpower and the habit. But we notice the resting energy expenditure or the basal metabolic rate. Let's say for a 200-pound patients, maybe let's say 1,800 calories, the basal metabolic rate. And then after they lose weight, the resting energy expenditure decreases, let's say, to 1,500, 1,300, something like that. And then if they do regain the weight, um, the basal metabolic rate doesn't increase back to 1,800. So, yeah, that's
Say
the
that
reason.
last part one more time. So it makes sense to me that, let's say at 200 pounds, my basal metabolic rate is 1800, my calorie expenditure per day is 1800 calories. So as I lose weight, obviously my body needs less calories because I don't weigh as much, right? I don't need as much energy. That part makes sense to me.
Yes.
So from that point forward, as your body calls for more food because you're
Yes.
hungry all the
Mhm.
time, and that's because of, I guess, ghrelin is probably stimulated. Maybe those adipocytes or those fat cells are calling for, to be fed. Talk us through from that point forward one
Yeah.
more time.
So if we then we may regain weight. So after we regain weight, our basal metabolic rate doesn't increase back to the previous normal value.
So it stays low.
It stays low.
Yeah.
At least. Um,
And what is the reason for that, do you think? Out of curiosity.
so because I think one thing is as we lose weight, if we don't lose weight healthily and retain the muscle mass, we lose some of the muscle.
Yeah.
Um, and It's been estimated if you lose weight without retaining the muscle, without trying to retain the muscle mass, we might lose up to 40% of the muscle. So that's why I always recommend having adequate protein intake and also doing exercise and strength training. And that's why I collaborate with you too.
Yes, that's a nice segue into, medical weight loss collaborating with physical therapy. So, obviously you've been a great referral partner of ours and hopefully, we are too for you.
You've been really happy.
It's, weight loss plays a huge role in physical therapy, for a lot of reasons. So it's really, it's a great combination of specialties. In physical therapy, we know that weight is directly correlated to knee pain, to ankle pain, to hip pain, and to low back pain. Any sort of increase in strain on the joints, and especially as we age, can affect morbidity and mortality as we age. So, uh, anything that can hit the root cause, safely of obesity or adiposity is a really great success for us. And if you could touch on, sort of what happens when folks take the GLP-1s, how is it discriminate toward, is it an indiscriminate 20% weight loss? Does it attack more muscle and fat? Is it both fat and muscle? Is it more fat than muscle? How does it work?
So, um, when patients after we screen and a patient is safe to take the GLP-1 agonist, um, if we um, do also the strength training, the resistance training, and the adequate protein intake, the muscle loss will be minimized. So the goal is to retain the muscle mass.
Yeah.
That's why we don't just prescribe and just let patient take the medication without any support. That's why we support that. So if not, then the 40% of muscle mass loss can happen.
Up to 40%.
Yes,
Yeah.
the 40% can happen.
Which will affect your basal metabolic rate greatly.
Correct, and also affect, as you know, the balance as we grow older, and yeah, and it's also patient will feel more fatigued as well if
Yeah.
they have less muscle.
Yeah. Can you walk us through, Gunardi, the screen for the GLP-1s
Yes.
and, so what you're looking for somebody who can qualify to take
Yes.
it, who a good candidate is for them. Um, yeah, I guess we'd start there.
Yeah. So I always ask patients like the why they would like to lose weight. So in some people it could be because of metabolic conditions such as like fatty liver or diabetes or like high blood pressure or my primary care doctor says that my cholesterol is high. My knee pain is of my knee pain is worse because of recent weight gain. So it's not only about the BMI. Of course, it's easier to screen using a BMI, but we go a step further. We do a also body impedance analysis in our practice. We have a medical grade CCAR device where we measure the muscle mass, where we measure the subcutaneous fat tissue and also the visceral fat tissue.
Yeah.
So for patients who are bodybuilder, their BMI might be 27, 28, and they might be considered overweight or even 30, but or even considered to have obesity. But they do not need to lose weight
Yeah.
because they do not have a lot of fat tissue. Yeah. So we do screen for that. So, but
Is there a percentage of body fat that you look at as sort of
yeah.
as a breaking point?
So for females, about 31%, above 31% is what we consider to have excess fat,
Yeah.
and for male above 24%. But there are ranges to that. What's an optimal? What's an athlete level? Yes.
Yeah.
Um, but yeah, for patients who have a BMI above 27, above 30, who have medical conditions, so I think it's a good candidate to try um, to try to lose weight and perhaps with medication support.
Yeah. I think that's great. I think, and talk more about sort of how you collaborate with physical therapy and how that works in your practice?
Yes. So after the screening, um, and after, let's say, prescribing the medication, I always offer them, "Hey, do you want to work with a physical therapist? We have created a program, so we can guide you to build or retain the muscle as you lose the weight." And I give them the stats. If you do not exercise, this could happen, and it might be an unhealthy weight loss, yeah, which we do not want. I especially encourage patients who have never done strength training before, because it's very important that they stay safe and injury free on that. Or patients with limitation like knee pain or back pain. Uh, I think it's better to have a coach or a physical therapist. And patients who have referred to so far has been really happy, and they not only lose weight but they feel more energized. One patient say, she's 50, female. She said, "Oh, now I could jump and reach the bookshelf," and she's very happy with that. And she's just beginning.
Yeah, that's great. I think, and I guess maybe I'd ask you, I'm sure some doctors send to personal trainers too. And, I think that it would be really important for somebody if you've got, if you're getting a GLP-1, if you're going through a medical weight loss program, you really want to pair with an exercise specialist, and a physical therapist,
Yes.
at least to begin your training program, because, PTs are trained to look at the whole body. We do what's called manual muscle testing. So we test the strength of all the muscle groups so we see where we're beginning. And then our goals are to improve both the range of motion and the strength of the tissue.
Exactly,
So
exactly. So, I've I've sent also another patient to your center, and they said, "Oh, instead of working directly for strength training, um, he said to me, "Oh, my range of motion was assessed, and I need to work on my certain range of motion before I do certain movement." So I think that's a great thing. I think physical therapy has the special expertise for that.
yeah, and I think, a lot of what I talk about, and it's funny because they don't really teach us in school. They give us all the basic parts, right? But it's up to us to put it all together when you practice in physical therapy and you start to, and you work in orthopedics. What I've found generally is that, especially as we age and, I guess probably the demographic that's typically, needing the GLPs or the obesity meds are probably 40 plus, 35 to 40 plus. Your metabolism starts to hit a wall. I've definitely felt it personally. Um, and, your range of motion just changes over time, and if you're trying to strengthen muscles that are short, you have to lengthen the muscles first, either through stretching, hands-on therapy. So we use like Graston tools, dry needling, shockwave techniques. You have to lengthen that muscle tissue so that it's at the proper length tension relationship before you can strengthen. So it's not just go to the gym and lift weights because they may have short muscles. And if they go, lift weights short, by short, I mean tight muscles,
Mhm.
they may go lift weights and it's not going to necessarily help because they're either going to hurt themselves and end up back in physical therapy
Yes.
in the second place. So it's, I think it's a perfect collaboration. The other question that I was going to ask you, Gunardi, was, obviously I want to talk about the side effects. And I do want to just touch on if you can kind of break down to a lay person or somebody who's listening to the podcast, the mechanism of action for the GLP-1
Yes.
and then what some of the side effects might be.
Yeah. So I always tell my patients there are three mechanisms of the GLP GIP agonists. Yeah. So
Oh, we're talking about how they work.
yes, yes. So GLP is a hormone that's usually naturally produced by the intestine,
Mhm.
and that usually has the uh, feedback mechanism, and that inhibits the ghrelin, which is the hunger hormone. So, patients have reduced cravings and reduced food noise with that. So it's yes.
What is food noise? That's the
So
first time I've heard of that.
oh yes. Um, so it's basically in the back of your mind telling you have some of that sweet drinks, have some of that uh, like burgers or some. So
Yeah.
um,
Whatever
patients
the gut microbiome is calling for. Right.
yes.
Yeah.
So they know how to eat. They know how to eat healthy. But then the hunger is the kind of the elephant that tells them to eat, and it's a real thing. And the GLP-1 can help reduce the food noise. So what patients tell me usually is, oh, I can decide for healthier food options. I'm not commanded by this craving or hunger food noise anymore. Actually, I like eating vegetables now. So that's that's one. And also, um, it's been there's been recent studies that say or that indicate that there is less alcohol craving with that. So even though it's not indicated for alcohol, but it works uh, in the brain signal to reduce the alcohol cravings as well. So I have patients who say, "Oh, actually, one drink is now enough, rather than the three to four.
Yeah.
So I still enjoy, but one drink is enough." So that's the first mechanism. The second mechanism, it increases the insulin sensitivity. That's why it's also used in treatment of diabetes. Um, but this is especially great for patients who I just saw today. She's been she's she's about 30 years old, and she's been exercising, eating healthily, tracking the calories, tracking the protein, the fiber, but she's not able to lose weight, even though she has documented her efforts. And then we started on a GLP-1 agonist 2 months ago, and she's lost about 15 pounds
Wow.
since then. And she hasn't changed anything regarding her nutrition and exercise. She has just continued the same healthy exercise and nutrition. In fact, she said, "Oh, actually, I have increased my meals more frequently now." So actually, she eats healthier, like not healthy, more meals, more healthy meals, and she's losing weight. And I've heard this from other patients as well. Um, so that's the second mechanism. And the third mechanism is where the possible side effect comes from. So because it reduces the speed of the transit of the food through the stomach and through the intestine, patient may experience nausea. Patients may experience like constipation or diarrhea. That's the most gastrointestinal symptoms are the most common side effect. But we can mitigate that. Yeah. So one is we always track, hey, do you have enough fiber? We always say counsel have 35 gram of fiber for men per day at least, and have 25 gram of fiber for women every day at least. So fiber. Water is also very important, and having smaller meals initially, and also having blender food. Um, so after a few weeks, gradually patients will be able to adjust with that, and they do not have any side effects. And as we know in the studies, 95% of them uh, are able to continue with medication without significant side effects. So, yes.
Now, are the GLP-1s a lifetime medication? Do you have to take it for the rest of your life, or is it just an on and off again thing?
So that's a great question. So, usually, we uh, we recommend to use them long term. However, um, I have some patients who would like to, after they have successfully lost weight, um, they change their lives, they eat healthily, they exercise 1 hour every day, because that's a number that I usually have the patient as an end goal, 1 hour every day. This number comes from the National Weight Control Registry. Patients who have lost at least 30 pounds of weight and have been able to maintain it for at least 1 year, 90% of them exercise 1 hour every day, not through moderate intensity or intense activity, but mostly by just walking. So if they have done all of that, hey, I think we can try and have patients who are successful and been able to maintain the weight. Yeah. The second point is that, as we know in the studies as well, um, patients who have lost 20% of weight with the medication, even if they have to stop for any reason, um, patients still able to maintain the 12% of the weight loss. So the more weight loss that they have during the treatment, the more if they need to be off the medication, they are still able to get at least the 12% of still the persistent weight loss.
Yeah, that's great. How quickly, Gunardi, does the weight loss happen?
So um, it usually takes effect within uh, a month, within a month, but patients lose weight gradually over a year period. And that's what patients just lose gradually. And I think that's a great thing because patients are able to retain the muscle with that because it takes time to build the muscle or retain the muscle. Yeah.
Yeah. Do you feel like it's now an antiquated thought process to, as a doctor or an internal medicine specialist or primary care, to tell your patient best way to lose weight, or to get off this cholesterol pill is for diet and exercise? Do you feel like that's sort of gone to the wayside, or do you like, what is kind of your thought process around that?
So uh, I still recommend lifestyle modification and nutrition. I always tell the patients or ask them, if you like to be off the blood pressure medication. Um, so I give them this information. Every 20 pounds of weight loss, the blood pressure drops by 10 points.
Okay.
So the systolic and the diastolic, the upper and lower number. And I want to help you be off the medication because you'll be healthier. You're happy. I'm happy. There's, it's easier to help healthier patients. So that's one. But for patients who they say, Doc, I've tried my best. I track, I log. Either I cannot lose weight even though I eat well and exercise regularly, or maybe the food noise is too big. Yeah, I I let them know. Hey, yeah, I recognize your efforts. Let's help you with medication. Because I think I mentioned to you just now the prevention and treatment of weight gain is different. For preventing weight gain, lifestyle modification is number one. Exercising and uh, uh, and nutrition, tracking the nutrition is very effective to prevent weight gain. But when we are there, it's harder to lose the weight. That's the thermostat analogy. Um, so, for example, patients who have uh, uh, to prevent pneumonia or lung infection, we always say to patients, uh, try to quit smoking and take the pneumonia shot if it's indicated, right? But then if they have pneumonia, we don't tell them quit smoking and get the pneumonia shot. We give them antibiotics. So it's the same thing for this. Yeah.
Yeah, that's interesting. So I think, and again, just to rephrase that, because I think that's a really powerful point, Gennady,
Mm,
is, for folks who are in shape, the
mm,
best way to stay in shape is
mm.
diet and exercise. But those who are obese or, happen to be endomorphs or, have a slower metabolism from genetics or other things, um, GLP-1s can be a real option to, just like an antibiotic can be an option for a disease. GLP-1s are really, I guess, treating the disease or the root cause of obesity.
Correct, correct.
Because what I'm hearing is that diet and exercise it's just much more difficult to lose 20% of your body weight with diet and
Yes.
exercise than it would be with. Do you have any stats around that, or is it just kind of?
Yes. So we have been studying in obesity medicine patients who are going through a program. I say every 2 weeks, the coach checks in nutrition counseling every month. Out of the 100 people, 5 people are able to lose weight and maintain the weight. Losing most of them can lose weight, but they are after 1 year mark. They will most of them 95% of them regain the weight.
Yeah.
So the 5% are successful.
And these are people working out 5 days a week for an hour, good
Correct. So have
nutrition.
with regular exercise, have a external support with a nutritionist monthly and coach every 2 weeks.
Yeah.
So yeah,
Those aren't amazing numbers.
yes, and the weight loss on average is about 5%.
Okay.
So um, some people for those percentage of patients, I think it's great if we should try the diet and exercise because exercise have other benefits besides just help with losing weight,
Yeah.
help with heart health and help with increasing increasing life expectancy as well in general.
And just attitude, and there's a lot of hormones that get stimulated with, with exercise that can improve their mood and serotonin and dopamine and, exercise is really important. But, I think especially as your metabolism gets older, as you get older and your metabolism slows down a little bit, and we talked a little bit about metabolic disease, um, it can be frustrating for folks, and I think a lot of people don't want to take any medications, but I hope that this conversation can at least create a dialogue between whoever's listening. If you're overweight, and you try diet and exercise, and you're trying diet and exercise, open up a dialogue with Dr. Irawan or primary care around the area who specializes in obesity management, because you don't have to suffer. You don't have to, live with the comorbidities of diabetes and, high cholesterol, high blood pressure. You can treat it in its root cause, uh,
And
without, and it's not cheating. It's truly like treating a disease.
yes, it's correct. So, um, if a it's like if a patient have asthma, um, we don't tell them, oh, that's just to breathe harder. We give them, if needed, inhaler to help with the asthma. So it's the or if patients have diabetes, we besides just counseling for lifestyle and nutrition, we have medications that can help with the diabetes to prevent complications. So that's my thought, and I think using the resources around you to help you improve your life, it's not cheating.
Yeah, and I think you're a great resource.
Oh, thank you.
So, in closing tradition, I ask a couple, questions. So, personal questions. So, first question is, what's your favorite movie?
My favorite movie. Um, I I like Lord of the Rings. I like the Star Wars. I like also um Western movies as well.
Oh, yes. My dad was a big fan of Western movies, Clint Eastwood, and yes, was the Magnificent Seven. Yeah, that was just a throwback. Yeah, the good, bad. Yeah, the good, the bad, and the ugly. It's awesome. And we're just down in Disney World, so I did the Star Wars. The kid
Oh,
took the kids to the Star Wars
yes.
rides, and it's just our kids. For our listeners, our kids are the same ages. 5 and 3. And my old Noelle is 6 now, but she just turned 6, and I took them on on that's the Star Wars ride. Which one is it? Where they ride the spaceship, or the Millennium Falcon. All the Star Wars fans
Oh,
listening are probably like, the Millennium
very
Falcon.
excited.
Yeah. And so my 3-year-old Jolie was on the ride. She was just like, or she was shaking the entire time. And then Noelle kind of liked it, but she was a little scared. I could tell because all the drops. It was their first ever ride at Disney World, so it was crazy. Favorite concert that you've ever been to?
It was a long time ago. But it was the Black Eyed Peas. But it was a long time ago. Yes.
Love that. What'd you like most about it?
Uh, I I like listening live music from so I can hear how they are before it's optimized.
Yeah, that's cool.
Yeah, and the energy from the people.
Yeah, I love that. And then you can think about this one because I didn't give you any preparation, but I guess, what I ask all of our guests is, a quote or a motto that they live by.
So, hmm, a cool or a motto that I live by and I might want to share with others is basically try to um, live the day you as best as you can, and try to be kind to other people on the way.
Yeah, that's nice. I love that. And then I guess my last question would be uh, anything else you'd want our audience to hear, or any piece of advice, one piece of advice for our listeners or your patients.
So I think o- there is stigma in obesity, and I think that's been going on for a while. And at least we should try to have the conversation and remove the stigma. And the medical community should remove the stigma from the patients because we are there to help people. Yeah, and then and if you're struggling with weight, so I think it's a good idea to discuss with your primary care physician. Um, yeah, and ask them what are the options. I'm sure they are happy to help. And if they do need help, you can always contact me. I'm available here in Northborough, Massachusetts, and we're happy to help. We are accepting new patients who can help. Yeah.
That's great. And so, just for any of our listeners, Dr. Gunardi is located in Northborough, Massachusetts. We'll include his details in the show notes. So, if you'd like to reach out to him, we will include those details in the show notes. So, thanks again, Dr. Irawan, for joining us. And it's
Thank
been
you
a
for
pleasure.
inviting me.
Yeah. And I think hopefully our audience learned a lot from this. So, thanks again.
Mhm. Thank you.